breastfeeding essentials. She continued her contribution to the community as a volunteer with different local NGOs, lactation educator with Lactica 2018-2019, breastfeeding specialist with LAECD 2019, a Lactica board member since 2019. She became an international board certified lactation consultant, IBCLC in 2020, and currently working in private practice.
Thank you, Nadine, for the introduction. And I want to start by thanking all the organizers for this wonderful conference and for the opportunity to be with you and to talk about my passion about breastfeeding. I just want to make sure if you're seeing my screen.
Yes, we can see your screen, yeah.
Okay, awesome. So I chose to talk a little bit about medication use in breastfeeding women. And I'm particularly interested in this subject because a lot of moms really are pushed or maybe choose to stop breastfeeding because they are ill or they have to take some medication. So hopefully at the end of this presentation, you would be having an overview about how to know if a certain medication is compatible with breastfeeding. I'll start by quoting the American Academy of Pediatrics because it technically summarizes the actual situation and the problem. It says physicians receive little education about breastfeeding and even less training on the effects of maternal medication on the nursing infant. Yet, concern about potential harm to the nursing infant from the maternal medication is often cited as a reason to advise discontinuation of breastfeeding. And this is true, by the way. An ill mother or a mother who has to take medication is among the top 6 reasons why mothers stop breastfeeding, according to the CDC website. It continued to say that overwhelming evidence demonstrates the benefits of breastfeeding and the deleterious effect that can result from premature weaning. So it's not really acceptable to advise mothers to stop breastfeeding or to wean or to introduce formula just because we do not have the enough knowledge about medications compatibility with breastfeeding. This study shows that mothers who are sick or had to take medicines had a 120% increase in the odds of stopping breastfeeding. So that's really a huge number, and it has a huge impact on breastfeeding and on weaning in particular. But when it comes to medication transfer via human milk, we can agree that a lot of medication do transfer into the milk in some amount. Most of them do transfer at low level, but not every medication that the mother takes produce clinically relevant doses in the infant, and not every medication will be able to produce infant side effects. So we really have an interaction between several components that are drug-related, maternal-related, and infant-related, and they have to be aligned in a certain way before producing side effects in the infants. So this is an idea about the process that a medication goes through before producing side effects. So it's a multi-level process. If a mother takes the medication orally per us, it reaches the maternal gut. It then has to be absorbed before reaching, in order to reach the maternal plasma. If the mother takes the medication via parenteral route, of course, we're going to skip step 1 and just jump into step 2. Once the medication is in the plasma, it has to enter the mother's milk. Once it's in the milk, the baby might just ingest the milk that contains the drug. It then has to be absorbed from the infant's gut and reach the infant's plasma. So only if the medication really reaches the infant at high levels or at significant levels, it might be producing side effects. And we should note that the medication might be blocked or hindered, or the concentration might be reduced at every step. So we might have a factor that would block the medication from being transferred from the gut to the plasma or from the plasma to the milk, etc. These factors usually are drug related. So they are related to the pharmacokinetics, and there is implication at different levels. So when we start by the maternal gut, I'm not sure if you can see this here, but it's the maternal gut. We have, once the mom just ingests the medication can be absorbed. It can also be destroyed by the digestive system, and it can be picked up by the liver for destruction, for storage, or for metabolization. So here's the oral bioavailability plays an important role. The oral bioavailability is the percentage of the drug that is absorbed from the mother's digestive system and that reaches the plasma. That being said, if a medication has a low oral bioavailability, this just means that it will not reach the plasma at very high levels. On the other hand, the metabolization by the liver is also important because a huge amount of medications are metabolized by the liver. And for the majority of the drugs, the metabolization is actually an inactivation. So the drug would be destroyed. And as a result, it will have a lower plasma concentration. So this is how a medication can be hindered from passing from step 1 to step 2, which is the maternal plasma. Once it's in the plasma, we also have 3 pharmacokinetic factors we can take into consideration. So of course, the drug level, which is the maternal plasma concentration. We also have the volume of distribution, which is how widely the medication is distributed in our body. Every medication can be distributed, whether just in the plasma, in the whole blood, or even in the organs. So a medication with a high volume of distribution is distributed technically everywhere in the body, and therefore it will have a lower plasma concentration. And the third factor would be the half-life. This conditions the elimination of the drug. We usually say that a drug would be completely out of our system within 5 to 7 half-lives. Of course, if a medication has a short half-life, it just means that it is eliminated rather rapidly and will be out of our system rapidly. Once in the plasma, of course, the medication can be transferred into the milk. Most of the medication are subject to passive diffusion, and this is driven by equal forces of until we reach equilibrium. So it's just driven by the difference of concentration between the plasma and the milk. It just means that once the medication exists in the plasma, it flows freely into the milk. But for the passive diffusion to happen, the medication has to be transferred through the cell wall. So it is transferred from the blood vessels into the blood-milk barrier, and from the barrier, from the cells into the milk. So this is why lipid solubility is particularly important for passive diffusion to happen. And this mechanism is very similar to the transfer of medication into the blood-brain barrier. So it's very similar. And this is why a lot of medications that are actually active on the central nervous system would exist in high amounts in mother's milk. Another factor that is important for passive diffusion to happen is the molecular weight. So a large molecule would not be able to pass this barrier because it has to pass through the cells. Usually a molecular weight higher than 800 Daltons means that the molecule wouldn't be subject to passive diffusion. And the third factor for passive diffusion to happen is the protein binding. So just to explain that, every medication that we take, once it reaches our blood, it either circulates as a fraction that is protein bound, usually to albumin, and the second fraction circulates freely. It's soluble in the plasma and it's free to go anywhere. So if we say like a protein binding of 90%, that's high. It's 90% bound to protein in the blood and 10% free circulating in the plasma. The section that is protein bound is not subject to passive diffusion since the protein is a large molecule. So only the free section that is available circulating in the plasma can do the passive diffusion. And thus, medications that are usually have a high protein binding are less available in the milk. And that's true, for example, for anti-inflammatory or for warfarin that have very high protein binding properties. And like I said, the passive diffusion is the main mechanism that is used by medication to be transferred from plasma to mother's milk. And by passive diffusion, we said that the aim is to achieve similar concentrations in the plasma versus the mother's milk. But just that means that like the medication can enter the milk, it also exits the milk. So once the medication starts to be eliminated from the plasma and the drug plasma level decreases, the medication would exit the milk and go back into the plasma to also be eliminated. And this is important to know because it's important to know that the medication will also exit the milk even if milk is not removed. So even if the mother doesn't pump or doesn't breastfeed or doesn't remove the milk, the medication will exit the milk and go back into the plasma to be eliminated. An exception to that is a mechanism called ion trapping. This is something that happens with medications that are slightly basic, like the barbiturates, because they have high pKa, and the pH of the milk is slightly lower than the pH of the plasma. So what happens is actually that they enter the milk through passive diffusion, but once they are in the milk, they get ionized, and an ionized molecule can't be subject to passive diffusion, so they get trapped and get concentrated in mother's milk. And another mechanism of transfer is active pumps. So active pumps are pumps that exist on the cell membrane, and they selectively search for the molecule in the plasma, and they capture it and throw it in the milk regardless of the concentration in both compartments. So they concentrate molecules in the mother's milk. And we have a very important active pump, which is the iodide pump. It selectively captures the iodine and throws it in the milk. And this is important to take into consideration when it comes to medication, especially when we're talking, for example, about radioactive iodine, which is a contraindication for breastfeeding, or if a mother has to take radioactive iodine, we resort to weaning because, of course, radioactive iodine would be harmful for the baby, and it is actively concentrated in the milk. So it's regardless of its elimination, it is also actively concentrated in the milk. And the last two levels are the infant's gut and infant's plasma, and we can think about the same pharmacokinetic properties applied for the infant. For example, if we're talking about let's say insulin. So insulin is a large molecule. It has a large molecular weight. It probably will not be subject to passive diffusion, so it will not be concentrated in mother's milk. But if a small amount does enter breast milk, what would happen? The baby would just ingest this insulin. It will reach infant's gut, and it's a protein, so it will get destroyed. It is not bioavailable, so it won't reach infant's plasma, and it will not produce any side effects or even any effect in the infant. An exception to that are actually the medication that might produce digestive system side effects. So mainly antibiotics. So if a small concentration of antibiotics are received by the infant, they might produce local side effects like diarrhea, like vomiting, like nausea. So if the infant is susceptible to these side effects, we might put them on prophylactic probiotics, for example, with the mothers on also on prophylactic probiotics to reduce the side effects. We also have two pharmacokinetic properties that are introduced specifically to breastfeeding mothers. They are the milk plasma ratio. For most medication, it's equal to 1 since they are subject to passive diffusion. But it's important to look at it because some medication, like we said, do not really enter breast milk or are concentrated in breast milk on the other hand. So it gives us an idea of how available the medication would be into breast milk. And the second one, which is very important, is the relative infant dose. This is a dose that is adjusted, weight-based, the infant received dose versus the mother's ingested dose, both adjusted weight-based, and it's a percentage. In general, a relative infant dose that is less than 10% is acceptable. I included some useful references. We have a book from Dr. Thomas Hale. He introduced a classification about medication use in breastfeeding women, and I'm gonna talk a little bit about this classification, but we also have reports from the AAP, from the WHO, and we have online resources like the Infant Risk and LactMed. These ones are free, by the way. So this is the lactation risk categories by Dr. Hale. What's nice about this category is that it is classified from L1 to L5, L1 being compatible. It takes into consideration the risk for the infant, but it also takes into consideration the risk of the medication on the breast milk production. Because if the baby is actually dependent on breast milk and we give the mother a medication that might drop her milk supply, we're gonna also endanger the baby because he will not receive adequate nutrition. So L1 is compatible because we have controlled studies with no proven side effect. L2 is probably compatible because we have studies in limited number with no increased side effect, or we have a demonstrated risk that is very remote. L3 is probably compatible because we have no controlled studies, or the controlled studies show only minimum and non-threatening adverse events. And for the L3, it's really depending on the clinician's advice, or maybe he has to weigh the benefit for the mother versus the risk. He has to weigh if we have other alternatives existent. L4 is potentially hazardous, so we have a risk of side effects, and L5 is hazardous, so we have a risk of very harmful side effects in particular. The L5 are mainly, for example, the cytotoxic drugs, the chemotherapy, and the radioactive iodines. These constitute the major part of the L5 category. So to sum up, most drugs are actually compatible with breastfeeding, contrary to popular belief. And the risk of formula feeding are well documented. So it's not really acceptable to introduce formula just because we have to take a certain medication, unless it is really justified. We should also advise the mother to avoid using unnecessary medication and supplements. When possible, we can select drugs with published data. So the more published studies and data, L1 or L2 would be preferable. And of course, like we said, we should avoid medication that might reduce mother's milk supply. When possible, the clinician should choose a drug with a favorable profile. So we can choose the one that has a short half-life, high protein binding, low oral bioavailability, and high molecular weight are also favorable, and a relevant infant dose less than 10%. When in doubt, or maybe when we don't have enough data, usually pediatric approved drugs are generally less hazardous than others. And in most cases, the ones that are studied, the relevant infant dose here would be much less than the clinically used one in pediatric or in infant population. And of course, we should be more cautious with premature infants, with the newborns, and with unstable infants, especially the ones with GI instability. Thank you.
Thank you,